So basic principle of spine trauma. This is a second lecture, and there is an overlap with the previous lecture we had because there is a strong association between spine, uh, cervical spine, and spine trauma, as well as head injury, and definitely there is a huge overlap in applying with the maxillofacial trauma as well as applying the advanced trauma life support in managing those patients. Um, we'll start with some definitions. So, cervical spine injury involves both fracture and spinal cord injuries. Um, Fracture easily can be detected with images, but the spinal cord injuries, sometimes X-rays or CT scan can miss them, and you have to diagnose those patients clinically by proper neurological assessment by looking for decrease in sensation, weakness, and other features. And this is happen specifically if we have no fractures to be detected on the CT scan, but we are dealing with the herniated disc, spinal cord contusion, or ligamentous injuries, which can be detected by MRI. We all know a huge social impact of cervical spinal injuries there, and has a tremendous both emotional and economic implications for patients and patient families. That's why recognition of those cervical spine injuries is really important and critical to avoid further neurological deficit, because if we miss those injuries and we start to mobilizing a patient with an unstable spine fracture, definitely the neurological damage will be worse. And we all know a facial and skull fracture associated with cervical spine fracture and spinal cord injuries, and the incidence of cervical spine injuries in trauma patients in general range from 1 to 8%. It depends on the mechanism, age, and severity of the injuries. And the incidence was definitely higher, reach up to 24% in postmortem study of the trauma patients. In a recent large studies, the maxillofacial injuries were identified in 3.7% of the patients. Majority of them were the motor vehicle accidents, and the major or the main clustering of injuries were in between C1 and C2 and C6 and C7. Both of them are in the cervical spine. And definitely those incidents increase with the severity of the injuries, as well as the bad Glasgow Coma scale and neurological status when the patient presents. This is a good and important question. When do we suspect presence of spinal trauma? So if our patient in the emergency department has a neurological deficit, weakness, numbness, a loss of neurological functions, if patient has a neck tenderness, and if there is an other injury distract from cervical spine evaluation, such as change in mental status, because those patients you cannot evaluate them clinically. If we are dealing with a really a high mechanism of injury, motor vehicle accidents, or fall from high distance more than 3 or 5 meters, all of those patients they have a high chance of having spine trauma. So we have to treat them as if they have spine trauma until we clear them by radiology as well as clinically. Um, how do we uh, period, how do we manage those patients? Um, we have to know early decompression of cervical spine, um, is really needed in those patients, because they have a better chance to have a better outcome. And most study suggest and recommend to be done within 24 hours. We all, and you know guys better, the definitive repair of maxillofacial fracture usually involve manipulation of the neck and the head, and doesn't need most of the patient to be undertaken immediately. So, patient with unstable cervical spine should underwent cervical spine fixation, and afterward we can deal with the maxillofacial repair and management. Surgery, what I meant. As we know, rapid hemostasis and temporary stabilization of mobile facial fracture will be adequate until the patients recover. In general, the management of spinal cord injuries go through phases, early and late. In early phases, um, we have to immobilize and um, in the patients and manage them as if they have cervical spine injury until proven otherwise. We have to do proper and full neurological assessment to identify any sign of spinal cord injuries. We have to watch for bed sores, because those patients can be in bed and in full C-spine percussion for too long. We have to keep their blood pressure on the higher side, MAP above 85. There's a controversial evidence about the role of steroids. Those patients, if they have spinal cord injury, they have a trouble with ball and bladder function and management. They have a high risk of DVT, so they have to be on a DVT prophylaxis. They need a good nutritional support, rehab, as well as psychological support. I will go just quickly through a common fracture we see, so you guys have an idea. You don't have to go into the details of management. If we are talking about spine fracture, we start from cervical. We start with the C1. We have the what's called atlas, and in atlas, the most common fracture called Jefferson fracture, when you have a fracture, two fracture on the anterior arch as well as posterior arch. Those are lateral mass um, 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 of the patients. And in general, all the fractures either doesn't need any treatment, or need to be treated in a color, or need more advanced external fixator like a halo, and we'll talk about that later. Or if it's very bad unstable fracture, then it's surgery. Okay, so that's in general in any fracture you are facing on the spine. So in C1, for example, if it's mild, completely stable, there is no huge displacement, um, we'll call it undisplaced, then those patients will be treated in just neck color. If it's very bad unstable, then we will put them in a halo. Sorry, I had pictures, but I don't know why it's not showing up here. But halo, basically, we have like screws with a ring fixed in the skull and connected with a brace of the chest and abdomen. Um, and if the fracture is completely unstable, and we have a ligamentous injuries, and then we have to go with surgery. Second vertebrae we have is C2, which called odontoid, and usually we get fractures here in an odontoid fracture, which is this part of the C2. Type 1 is almost stable, and it's just the tip of the odontoid. At the base, they get type 2. When it goes in the body of the C2, this is called type 3. And usually um, can be treated the same principle as I mentioned, color, halo, or surgery. We go with surgery if there is a progressive and incomplete spinal cord injury with a displaced irreducible fracture with cord compression. So basically, if you have in if whenever you have spinal cord injury, most likely this fracture is unstable and needs surgery. Um, Sometime borderline. If we try conservative treatment and there is no non-union, the fracture is stable, then we proceed with surgery. Still in C2, because this is C1 and this is C2, we had another fracture called hangman's fracture, which is a fracture through the pars interarticularis. And it's the same principle, type 1, type 2, type 3, type 4. And you can see looks stable. In compared to this, you see this part here. I'm not sure if you guys are following it, but here looks stable. But in type 3, you can see this part is displaced in compared to this, and it's angulated. So basically, this need fixation. Type 3, this one can be treated in a color. That's what we just mentioned. If you decided to do something urgent or emergency surgery, you have to keep in your mind um, consideration with anesthesia in those patients, because if we are suspecting spinal cord injury or unstable cervical spine, sometimes we have to do intubation while the patient is awake so we can monitor them. During positioning, we can, and if you want to flip them or something like that, you can keep them in a halo to keep them in place. um, Sometime we need um, um, to put them in neuro monitoring so we can monitor the neurophysiological and function of their lower extremities and upper extremities. If we are doing something wrong, that will be clear. Do follow-up x-rays after the positioning. And the same thing, we have to watch for blood pressure. So this is just general consideration we have to take care of whenever we are suspecting spine injury or unstable cervical spine. If you have to involve and do procedure on those patients, you have to be careful about those. Afterward, we'll talk about the thoracolumbar. We skip the subaxial cervical, but then we move to thoracolumbar spine or dorsolumbar spine. This is just general. You have vertebral body, then you have the cord inside and nerve roots, and then you have the posterior column. It's supported with bone as well as ligaments. And here you can see the spinal cord with the nerve roots coming out of it. Every part and zone has specific function. Um, um, this is how we do our sensory examinations and test for every area in the body. Every area linked with a specific area like C4 or L3 and the spinal cord. What I need from you really is knowing this Asia impairment scale, just this one. This has been pretty public now, and people uh, communicating using it, and basically just give you a hint or determine how bad is the spinal cord injury. If the patient has a complete spinal cord injury, and that's mean there is really no function below the level of the injury, zero. There is no sensation, there is no motor power, there is no response, then that's called A. If the patient is normal, is E. B and C and D, it's in between, depend on the severity. If you have only sensory, that then you get B. If you get some motor but it's very weak motor, then if it's like 50% less than 3 power, then you get C. And then D if the strength, if the weakness is not severe, and then E is normal. You have to know this because sometimes maybe you find it in the chart this patient is Asia A, so that will give you a hint how bad this patient has spinal cord injury. Common fracture we faced in those patients, especially when we have fall from height, thoracolumbar area, because it's transitional zone between the dorsal and lumbar, or thoracic and lumbar. So that's interesting. unique area, high incidence of injury and fracture with. And here just some pictures show you how bad the fracture can be. MRI can show you the ligaments and the fractures. That's why it's more accurate. As well, it can show you the spinal cord injury. You have to look for other injuries. So if you have a dorsal or lumbar, look at cervical. If you have a head injury, look at lumbar. If you have facial, look at the facial fracture. Look at the brain as well as the um, lumbar and dorsal spine. We always be concerned about stability. So if you have a fracture and it's stable in place, then really we don't have any problem with it. Most likely the fracture is going to heal. Even if the patient get mobilized, they will not injure their spinal cord. So stability is important to keep the maintain the posture of the patient, as well as to protect the neural element. And we consider a stable spine when we maintain normal alignment and protecting neural element under normal physiological loads. And that's mean whenever the patient stand, walk, run, they will maintain their postures alignment, and there will be no neurological deficit. We have anterior column, we have middle column, and we have posterior column, and that's like vertebral body, spinal cord or nerve is here, and that was your column. This is just one of the principle has been used. It's old now, it's not using anymore. They tell you if you get this anterior column, posterior column, like two of those columns injured, most likely this patient unstable and need fixation. And this is just give you guys an example. You can look as how bad is this fracture, and you can see how bad the spinal cord, which is this compressed, and definitely this patient needs surgery. We use more complicated criteria to tell us if the patient is stable or not stable. You really don't need to know this. You don't need to worry about it. But sometimes, even for a maxillofacial surgeon, looking at just simple X-ray, you can tell there is a problem, and it should not get missed, because this patient surprisingly had, yani it's a miracle. This patient has a normal neurological function, um, and had an X-ray, and if no one make attention to it, it will get missed. But if you look here, that's the spine, isn't it? And then when you get here, you can see the spine where it's coming. It's completely shifted. Like this is very bad fractures, and in those patients, and here it's again those patients, definitely it has to get full images, full pictures. You see it here again, and just show you, even as X-ray can show you, and look how much an amount of fixation he needed to fix and reduce this fracture. Cervical spine, C1, C2 we talked about. It's a special because it's different anatomy. Then C3, C4, C5, C6, more or less like dorsal and lumbar. And fracture, it can be mild or it can be severe. Just in general, this general criteria, once it depends on the appearance of the fracture. If the fracture looks very bad, most likely need fixation. If there is a ligament injury, that patient most likely need fixation. If there is a neurological deficit, most likely this fracture is unstable and patient need fixation. I'm really apologize. I will send you the final presentation because this is not the updated one. Um, but in summary, cervical spine injury um, associated very commonly with traumatic brain injury, as well as the facial fractures. Okay, always try to immobilize those patients. And if those patients are comatose, you have to consider and treat them as if they have unstable fractures until you clear them with the proper images, CT scan, X-rays, an MRI if you need it, as well as clinically after they get out of their coma, out of the sedation. Do proper neurological assessment. Be sure patient doesn't have the neck stiffness, especially when we are dealing with high mechanism injuries. Okay, motor vehicle accident, falling for really high distance, and try to avoid missing injuries, because mobilizing those patients, clearing inappropriate clearing their spine as free of injuries, it will risk your patient to have a worsening neurological deficit. And by this, I reach to the end of my lectures, and I will give you space, guys, if you have any questions.